Hi, this is Matthew Kruse with Creighton Radiology, and welcome to the mini lecture on PET imaging basics in oncology. Let's go ahead and get started. Let's begin with the case. This is a 75-year-old man with a 60 pack year smoking history who presents with an 8 mm pulmonary nodule. Here we can see the axial CT image of his chest on the left of the screen and a coronal image on the right of the screen. And the pulmonary nodules in the right upper lobe, indicated by the arrows right here. So this patient was referred for an oncology PET-CT to evaluate the level of suspicion in this nodule. Here we have some images from the PET-CT. The image on the left of the slide is a MIP, or maximum intensity projection image, which is a three-dimensional representation of the PET data. The images on the right of the slide are axial slices through the pulmonary nodule. You can see there is mild FDG uptake in the pulmonary nodule, best noted in the PET-only image at the bottom of the screen. But this activity is very mild, and we have to think about what should be the next step for this patient. Before we continue with our case, let's talk about positron imaging in general and how we obtained these images. Depending on your background in physics, you may know more about this than I do. What is a positron anyway? A positron can be thought of as an electron but with a positive charge. It's sometimes known as a beta plus particle. This is the antiparticle or antimatter of an electron. Radioactive elements or radionuclides that are unstable and have too many protons transition to a lower energy state by emitting positrons. Specifically, a positron is emitted when the transition energy is greater than 1.022 mega electron volts. A majority of positron emitters are produced by a particle accelerator known as a cyclotron. Positrons can combine with an electron to produce two 511 kiloelectron volt photons. This process has the dramatic name of annihilation. Some examples of positron-emitting radionuclides that are used in imaging include fluorine-18, which we'll primarily be talking about in this lecture, nitrogen-13, carbon-11, gallium-68, and rubidium-82. Now, what is a PET system? PET stands for positron emission tomography. But the catch is that no positrons are actually imaged. In the figure on the left, we see that a positron is emitted by the radionuclide, then travels a short distance in the tissue before undergoing annihilation. This process produces two 511 kiloelectron volt photons that are emitted nearly exactly 180 degrees apart. The PET detector uses this information to localize the activity to a certain place in the patient's body. The image on the right is an example of a PET detector with multiple detectors in a ring orientation. This is just the PET component of the scanner. A CT scanner component would be positioned next to the PET component just outside the image. F18 fluorodeoxyglucose, or FDG, is the most common oncology PET radiotracer. Fluorine-18 is a positron emitter with a half-life of 110 minutes. This half-life is helpful in that it is not so short that you need to have an on-site cyclotron to get the radiotracer, as it can be shipped to local or regional hospitals. Yet the half-life is not so long to incur unnecessary radiation dose to the patient. F18 has a relatively short positron range in the tissue before annihilation, and this results in better imaging quality and resolution as compared to some radiotracers. FDG can be considered a glucose analog. It's handled by the body similar to glucose with some exceptions. Glucose is upregulated in tumor cells as compared to normal cells due to increased GLUT transporter expression and increased hexokinase activity. The downside is that these transporters and enzymes may also be upregulated in sites of infection or inflammation. So FDG is not a specific radiotracer. These are 3 examples of a normal distribution of FDG within the body. Again, these are MIP images, a 3D representation of the PET data. You can see that the brain is an obligate glucose user, so usually is the most intense organ within the body. You can also see that unlike normal glucose, FDG is excreted in the urine, so you'll see intense activity in the renal collecting systems and in the bladder. There is variable activity within the tonsils, as noted in the left patient, within the myocardium, noted in the left and middle patients, within the stomach, noted in the left patient just below the heart, and within the small intestine and colon, most intense in the right patient. These are all within the range of normal activity. Now let's return to our case, the 75-year-old man with a pulmonary nodule. I would have interpreted this scan as mild hypermetabolism or FDG activity within a right upper lobe pulmonary nodule. I think this is indeterminate. Although it's less intense than typically seen with lung cancer, the small size of the nodule may limit our assessment. This patient should undergo follow-up imaging with CT chest in 3 to 6 months to evaluate for any growth. Unfortunately, that did not happen. This patient was lost to follow-up and then returned 4 years later. He also did not stop smoking, so now he's 79 with a 64 pack-year smoking history. Here's a repeat CT demonstrating increased size of the nodule, now with spiculated margins and surrounding ground glass attenuation, which may represent a small amount of hemorrhage. A repeat PET-CT demonstrates intense hypermetabolism within the nodule, suspicious for lung cancer. You can see on the MIP image in the bottom right of the slide, there's also a hypermetabolic lymph node. This was found to be pulmonary adenocarcinoma with right hilar lymph node involvement. I want to briefly mention some other oncology PET radiotracers that are not FDG. This is a growing area of nuclear medicine, tumor-specific imaging and treatment. Neuroendocrine tumor imaging has expanded in recent years, and this is based on agents that bind to somatostatin receptors, which are overexpressed in neuroendocrine tumors. This may be non-functional tumors, such as carcinoid, as well as insulinoma, glucagonoma, etc. A radiotracer that is very commonly used in this setting is gallium-68 dotatate, and there are both diagnostic and therapeutic versions of this radiotracer available. Another expanding area is prostate cancer imaging. Several radiotracers have been approved just in the past couple years relating to prostate cancer. Specifically, these are agents that bind to prostate-specific membrane antigen, a surface protein on prostate cancer cells. 2 examples are gallium-68 PSMA11 or F18-DCF-PYL. These also have both diagnostic and therapeutic versions available, offering a way to specifically treat tumor cells with radioactive elements combined to these specific tracers. This concludes our talk on Introduction to Oncology PET. Thank you.